Okay.
Well, this documentation guide that I made, and through my
Lisa?
guidance and our teaching.
We're going to start. This is Nicole Patterson Sampson.
Well, my maiden name was Sammons. I changed it to
Sammons.
Patterson, yeah.
Oh, okay.
My married name is
She's
Patterson.
a pediatric ER physician, and she is going to do a presentation on environmental emergencies.
All right. So we're going to be talking about environmental emergencies and basically things that are just applicable to people in Florida. And we're not talking about like cold illnesses and stuff that we don't really see. So I pointed it. I presume this.
I turned it on.
If not, I can just use the buttons on the computer. I can just use buttons.
You need a battery.
As long as is my hand going to be in the in the picture? Probably. All right. Okay. So, Margaret, am I totally blocking your way?
No.
Okay. So we're going to be talking about heat-related illnesses like heat stroke, heat exhaustion, heat cramps, electrical injuries, high and low voltages, and bites and stings is kind of the majority of our talk today. So as far as heat illnesses go, heat cramps are kind of the most benign form, and that's something that hopefully you won't see in the hospital. But that usually happens after you're done working out. You just get cramps pretty much anywhere. They could be in the abdomen too, which could be kind of confusing as well. And usually that's because you haven't had enough salt intake. So you might have a lot of free water, but no salt, and that can lead to cramps. Usually these people actually are in shape, and it happens like when you're in the shower or resting. You don't need to do anything about it except hydrate them, cool them down, and if for some reason it's really bad, give them IV fluids, but hopefully we're not seeing these type of people in the ER. Heat exhaustion is the next step up. There's a fine line between heat exhaustion and heat stroke. Heat exhaustion, usually these people are not acclimated to the weather, they're out of shape. You kind of hear about these sort of, if they're running a marathon and they didn't really train correctly, these might be those folks. Two main types: not enough water replacement or not enough salt replacement. Usually we see the majority not enough water replacement. The salt replacement issues comes in play when like cystic fibrosis patients who lose too much salt, that kind of thing. For not enough water replacement, you can have some abnormal symptoms, so your temperature can get really high, but generally the consensus is it's less than 104. Usually heat stroke is 104 or 40 degrees or above. Thirsty, your headache, your vomiting, you're usually sweating, whereas heat stroke, you're not sweating. You could have altered mental status, and you could be shocky. So depending on the severity of how these people present depends on the treatment. If they're not so bad, you cool them down, you give them PO hydration, or if needed, IV fluids. For the not enough salt replacement folks, if they truly are having a low sodium issue, then you might need hypertonic saline, but that's pretty unusual. So heat stroke, this is the life-threatening one. You can have up to mortality of 15% in adolescents. If you cool them rapidly within the first hour, it decreases the mortality by quite a bit. Usually these are either the very young, the very old, athletes, just because they're more at risk for having heat issues, and then drug-induced things like cocaine, methamphetamine, that sort of thing. In general, the heat stroke, was the usual consensus is, although different resources you look at have a little bit different of a temp, but most of them agree that it's 40 degrees or more, plus altered mental status. And this is hyperthermia, so external heat source or drug-induced heat source, not like a child with a fever who's a little cranky and has a temp of 104. So this is heat-induced hyperthermia with altered mental status. Usually these folks are not sweating, so that's kind of counterintuitive because your body should sweat if you're that hot, but that's another reason why they don't fare so well. Their muscle starts breaking down, which can cause kidney failure. They can be really shocky, and so you really want to identify these folks and treat them rapidly. And even if you get the temperature down in the first 24 hours, you can still have altered mental status after that. So for these folks, it truly is a medical emergency. So you do want to sort of see if there's any end organ damage, because if you're not perfusing all your organs, you can have renal failure, liver failure, coagulopathies, all kinds of stuff. And so you kind of want to get a rainbow tube on them, including coags, because they actually can go into DIC. And then depending on the patient population you're with, considering a troponin for end organ damage, and if they're shocky and stuff, considering an EKG as well. Renal failure and acute tubular necrosis occurs in up to 35, so about a third of patients can get kidney failure. It's usually more of a transient thing, but it's for three main reasons: the heat itself, the ischemia because of the lack of blood flow, and then the buildup of the muscle breakdown clogs up the kidney as well. And then you definitely want to monitor these peeps really closely with not only their vital signs, but also their urine output to make sure they're recovering okay, and on a rectal probe thermometer to monitor their core temperature. So for heat stroke, the general treatment is to cool them down. So if they're hot, cool them down. So the main things you want to do is strip them of their clothes, get ice packs in the groin and axillary areas, and then the methods of active cooling depend on what you want to do, but the most efficacious and the least invasive is actually running a fan with tap water over them. That's actually just as efficacious as doing an incredibly invasive peritoneal lavage and flushing ice water into their belly and taking it out. So the cool tap water, so if a physician or something is like, oh, we got to do this, then that's actually just as efficacious, especially for children as well. But you want to do the general kind of common sense thing of taking off their clothes and actively cooling them with ice and stuff too. Cold water immersion, so like literally immersing their bodies underwater, actually can work the best, but totally contraindicated in children. One, because they could slip under the water, but two, because it's really hard to monitor them too, and if they're in cold water, then that can lead to shivering, which causes more muscle breakdown, and then it's, you know, counterproductive. And so although it is pretty efficient, it's definitely not something we do. They usually reserve that more for those heat exhaustion folks, like at marathons or something like that, where they can just go sit in that tub of water kind of thing. But these people who definitely have altered mental status, you don't want to stick them in a giant tub of water. It's a little bit dangerous. So also, some things that we hear from parents to, for little kids with fever, they give alcohol baths, which is a big no-no, because then you can have systemic, I know everyone's like, no, big systemic absorption of alcohol, which in itself can be dangerous. And then like we talked about, monitoring via a rectal probe is going to be your best way to keep actively monitoring their temperature. So depending on how bad they are depends on whether they need to have a protected airway, and also depending on how bad they're shivering, like we talked about, if they're shivering then they can break down more muscle, which can lead to more renal failure and that kind of stuff, and it can lead to more heat production as well. And so if they're shivering that bad and they're not intubated, you can still give benzos to help calm them down, but or if it's really that bad, then you need to intubate them, paralyze them, sedate them kind of thing. A lot of EMTs had asked me before about using Tylenol or Motrin in heat stroke victims, and you definitely don't want to, because that can lead to kidney damage or liver damage if you're not processing, and it's not going to help at all. Since this is not fever, those aren't going to work at all. So kind of the fine line between hyperthermia and fever. And then another interesting thing is that you do want to stop actively cooling them, so the ice packs, the cool water fans, once they get to 38 degrees, because if you go any farther, then you can kind of overshoot your goal, and then you can get hypothermia from that, because your brain lags a little bit behind your core temperature. I'm sorry, the other way around. Core temperature lags a little bit behind your brain. So as far as blood pressure support, IV fluids are kind of your mainstay. Once you've sort of maxed out on those, though, dobutamine is your best pressor choice, because it helps to keep the heart rate up. It's a good inotrope, so it helps to keep the heart rate up, but it keeps your vessels dilated so you can allow for heat release. You don't really want to use some of our more common blood pressure meds like epi or dopamine, because it causes constriction of your blood vessels, which will reduce the heat release of everything. And then I know in adults they don't really use atropine that much for intubations, but for kids sometimes you do if they're really young, and you want to avoid that in heat stroke, just because that can cause elevated temperature as well. And as far as cold IV fluid infusion, you guys know, we never do that because that can lead to arrhythmias. Warm you can for other things, but not so much cold things. It can help, but it can also make them die. So moving on, that's pretty much the big thing to take away from the heat-related illnesses is heat stroke and how to treat it and how to rapidly identify it, because everything else will kind of go away on its own. So electrical injuries we're going to talk a bit about. We've got the man-made stuff and then lightning. So lightning strikes here close and dear to our heart in Florida. Surprisingly, only a third of people with the risk of mortality from lightning strikes. I would have imagined it to be more, but that equates to about 100 deaths a year in the United States. Lightning is direct current, whereas man-made electricity in general, household electricity, is alternating current, and that does make a difference. Lightning strikes, if someone gets hit by lightning out in the field, you're most likely to have them in asystole, whereas other man-made things, and even the high voltage man-made things are going to be like VFib and that sort of presentation. Lightning strikes, in addition to asystole, you'll get superficial burns. You won't really see much from the outside, but a whole lot will be going on the inside. And lightning is usually about 100 million volts of electricity. So the non-lightning electrical injuries cause about 700 deaths a year in the U.S., 10% of those which are children. Like we talked about, usually it's alternating current. Usually causes VFib, really deep burns. Frequently you get a lot of muscle injury, so you get a lot of renal failure and rhabdo, and a lot of time the burns are so bad that you have to do fasciotomies so that you can help perfuse things that need perfusing. So the severity of the injury, kind of common sense with some things, but just to spell them out. It depends on the resistance. So the least amount of resistance is more injury. Wet, thin areas like the mouth, so if a kid bites on a cord or something, that's going to be more injury than if it was a dry, thick area of skin. The type of current, like we talked about before, direct current versus alternating current. Nowadays, alternating current is what you're going to find usually in the man-made things in the household electricity. And that's more dangerous at the low voltages because the current goes kind of off and on. It doesn't really allow you to let go, so you kind of get stuck hanging on to whatever it is that's shocking you. The duration of contact, obviously, is directly proportional. And the pathway of current, if you got hit in the head and it went down, that's going to be a lot worse than if you got hit in the foot. So outcomes. So this is sort of a list of the most severe outcomes, regardless of sort of what it is that got you. But as far as lightning goes, the worst that could happen is that it kills you or you go into asystole. Interestingly, though, the respiratory muscles in the lungs are a lot slower to respond, so they might gain their heartbeat back way before their lung function. You could get an intracranial bleed from direct vascular damage, or if you had a high voltage thing that you went and touched and you got thrown from the source and then smacked your head. The alternating current can cause tetany and kind of constrictions of your muscles so bad to where you can get dislocations or fractures. GI hemorrhage is kind of an interesting thing just from direct damage. You can actually perf your gut. And then ocular damage, another interesting fact, especially with lightning, is that it can cause direct damage to your optic nerve. And so these people could present with fixed dilated pupils that you would generally assume is a really, really bad outcome scenario. But sometimes that's actually a regainable function. So if they come in fixed and dilated in asystole, you gotta kind of have a prolonged resuscitation to make sure you're not sort of missing that period where it's actually just sort of the direct damage covering up a potentially recoverable person. And that's kind of what we're talking about in the first one. So kind of the disposition and what you should do if they come in. So minor household electrical injuries. Most households aren't going to have the high voltage thing. So what we see most is like kids sticking things in sockets or biting on a cord, or a person trying to fix something and they get shocked. So if it's a minor low voltage household injury and they're completely asymptomatic, so no numbness, no tingling, they didn't black out, nothing like that, then actually supposedly you don't have to do anything. I don't know, I'd probably be safer than sorry and get an EKG, but theoretically you actually don't have to do anything. And they can go home. If it's a low voltage and they have mild symptoms, so they have a little numbness or tingling, they have a tiny little superficial burn where it made contact, then you actually do want to get an EKG. They recommend getting a urine on them to check for blood and protein, and then you just monitor them for a couple hours, which generally in the ER it's going to be that long anyways. And then if it's bad, if it's a household injury but they actually blacked out or they presented with some sort of arrhythmia or palpitations, then you actually do want to get the EKG, the labs, and you actually want to monitor them about 12 to 24 hours at least to make sure they don't have any recurrent or persistent symptoms. And high voltage, kind of common sense. If they got, if they went over and touched those danger high voltage areas or they got struck by lightning, obviously they're probably not going to present asymptomatic, but you want to watch them regardless. So that's kind of the main things over electrical injury. Other random thing on electrical injuries is the kids that have oral mucosal bites of something. So if they bite onto a cord or something, about a week later, they can, when that scab falls off, they can actually have some pretty profuse bleeding about a week after those kind of things. Just a random board question for us. So moving on to bites and stings, which is the most of what we got going on here, things we see a lot. So first we're going to talk about marine invertebrates. So that's your jellyfish, your Portuguese man o' war, that sort of thing. So these guys have these things called nematocysts, which around their tentacles, which usually help with prey. But if humans get up in there, then they can get stung as well. So what happens is once they make contact with something, they shoot off these barbs with these nematocysts, and then they release the venom, and then all goes downhill. So most of the marine invertebrates actually cannot penetrate through human skin. We kind of just know of the ones that do. And the free-floating ones, like the jellyfish, the Portuguese man o' war, usually do a lot worse damage than like the anemones and that sort of thing. So Portuguese man o' war from the top looks kind of pretty, from the bottom looks kind of awful. These guys are actually a colony of animals, which I thought, I do have the classes and stuff listed here, mainly just because it's kind of interesting. Not that I expect anyone to remember anything, because I don't even, but they're in the class Hydrozoa, which, like I said, is a colony of animals. So it's actually a bunch of different animals, not just one guy. Their tentacles can be up to 75 feet long, which is ridiculous, and each tentacle can have almost 1 million nematocysts, so you can get some pretty bad damage, usually on the Atlantic coast of the U.S., and one of the most powerful marine toxins, even if you find them dead on the beach. So, I mean, we all know this, but the tourists don't quite so much. So usually local symptoms are going to be pain and irritation. So this guy over here, he got stung by a Portuguese man o' war and has just the local irritation, and that's sort of your best case scenario. You can get systemic symptoms. So overall, you know, worst case scenario is going to be hemolysis, renal failure, death, if it's a really bad area. But generally, moving on, jellyfish, totally different class, not a colony of animals, they're just one animal. Really, honestly, they usually just cause local irritation, unless you have some allergic reaction to them, or if it's some other random one. But around here, usually it's going to be local irritation. These guys, I haven't heard of them being around here, but they say that they're in the Atlantic areas and the Pacific areas, the lion's mane. They actually are extremely toxic, and if they sting you in large areas, can lead to respiratory failure. But again, local is burning. So this is the big difference between all the other bites and stings. So as far as man o' war and jellyfish stings go, the biggest thing to know is that those nematocysts, if you contact those with fresh water due to osmosis, they'll release more stuff. So if you still have tentacles attached or those little dewies attached to you, you got to use saline or salt water to get them off, because if they come into the ER and you wash them off, they're going to be burning even more. And so you want to remove the tentacles with some object, not your hand, whether it's a credit card if you're at the beach, or a stick or whatever. Get those off of you, and if you happen to be at the beach and you get stung, you want to remove it in the salt water, and the salt water helps you get them off. And then once the nematocysts are all off of you, then you want to do hot water, because it's a heat labile toxin, and so it actually helps with the hot water. And it's really hot, like over 104 degrees hot. And you want to do that for about like 30 to 90 minutes if possible. And then if they do have a systemic reaction, so an allergic reaction, anything like that, you basically just treat supportively according to whatever they present with. And as far as those like burn marks go, you can use topical steroids, calamine lotion, that sort of thing. So other therapies that you always hear about a lot on TV or in the movies or wherever are sort of what else to do. Do you pee on it? Do you put ammonia on it, vinegar, whatever? And they've actually done a lot of studies on that. The pee thing's out. It doesn't work. The pee and ammonia don't work. But vinegar, baking soda, and meat tenderizer, that actually can help inactivate if they're still stuck on you, then it can help inactivate the little nematocysts. They've shown that vinegar, so acetic acid, is actually the best one if you're going to choose that. But unfortunately, there's so many different types of jellyfish, and thankfully not such an issue here, but in Australia it can be, is sometimes that can actually make it worse. And so generally hot water, honestly the easiest thing to find compared to like vinegar, but hot water is recommended for most everything. Like I said, after you've rinsed everything off with saline. And like in some places in Australia where they're out in the middle of nowhere and they don't have hot water, but I guess they have ice packs, apparently they try ice packs. But I don't know, apparently it doesn't help that much. And then like I said, alcohol, urine, ammonia, they actually sometimes can increase the nematocyst discharge, which is going to make it worse. So, although a good friends episode, not really helpful in real life. So sea bather's eruption is a pretty terrible thing. So it's the same little nematocysts, but they get stuck in a bathing suit or a wetsuit, and people don't know that they're in there and don't wash them out, or just don't wash them out. And so every time you put that on, it's going to cause a bunch of irritation. And sometimes you can get more systemic symptoms, kind of like flu-like illnesses, but in general, it's more that local awful irritation that can last for a week or two. And so you just want to treat those supportively as well. Topical steroids, antihistamines as needed, and calamine lotion. And so we got our sea corals down on the right and the sea anemones. I had a hard time saying it yesterday. But the Anthozoa class includes like your soft corals, your hard corals, and your sea anemones. Usually don't really cause much damage. I mean, if you go up and touch it, you might get, like with fire coral, that's kind of another subject, but usually pretty mild irritation. Usually the biggest concern is on the stone corals if you accidentally cut yourself, and then whether you're at just increased risk of infection or they actually inject the nematocyst into your laceration. And so that's where the troublesome part can come from. So again, same kind of thing, since these are like nematocysts, you want to rinse them off with saline first, and then you soak them in hot water. And for these guys, you want to make sure you remove any foreign bodies and that you don't have any retained foreign bodies. For almost every ocean-related laceration, you don't want to cut those up, or sew those up, excuse me, because there's such high risk for infection. And so if someone had a really bad wound, what you want to do is what we call delayed closure. So you send them home on antibiotics after a couple days, make sure that they're healing okay, and then you can actually come back and have it sewn. Honestly, usually people just forget about it and don't come back, but that's one thing. So different class of animals here, starfish, sea urchins, and sea cucumbers. Obviously the sea cucumbers down here on the left, and starfish don't do anything, and they're just kind of cute. But the sea urchins are pretty spiny, and they don't have any venom or anything, or any toxins, but you obviously can get if you stepped on one, it can get stuck in your skin. And the spines are made of calcium carbonate, so presumably they would show up on x-ray if you did get stuck. But you want to try to remove any foreign bodies. And if for some reason you aren't able to, then you just tell them to go home, soak their foot, because it usually resorbs on its own. And what's recommended is antibiotics only if infection develops. I usually like to play it a little safer. I'm a little, you know, I'm a little safer than not. I feel like anytime in the dirty salt water, if you get a wound, then you might want to make sure they don't get it infected. So that was all invertebrates. Moving on to the vertebrates. So stingrays we see all the time. They can get pretty dang big, up to 14 feet. Their spines, obviously, down here in the right, you can see the barb. It's a retropointed barb that basically stabs you, and then once it stabs you, the venom is released into your skin. Usually just a self-defense mechanism. Poor things get stepped on all the time. This guy up here in the picture, you can tell, pretty edematous, red. You can get a little local necrosis. The pain generally peaks within about an hour and a half. So if you can sort of get their pain under control within the first hour and a half, then usually they're good to go. But you can get excessive bleeding depending on where you poke and what you lacerate. Systemic symptoms you can get. So you definitely get the local symptoms, and I'd say that's usually what we see. And interestingly, though, you can get syncopal symptoms or almost passing out symptoms, not only just because they're like, oh my gosh, I saw blood and something stabbed me, but the venom itself actually can cause pre-syncopal symptoms. So it's not just them being a weenie. In rare circumstances, we don't really see it that often. I don't know if you guys ever had, but supposedly sometimes the venom can sort of affect areas of your brain, and then it can affect your respiratory drive, and it can cause conduction abnormalities of your heart. So presumably these people would present with symptoms, and presumably this would be in that first hour and a half. So usually we would see them at that point in time, and so we would know if that was going on.
I've never seen anybody with stingray. It must be because most of the stingray species are very small.
Yeah.
Rays, they're the little ones that line up in one.
Right.
To the beach. I've never seen anybody who's been venomated by a very large
Yeah, no.
ray.
Us either. We just usually get people that are like, I got bit by something. And they're like, I stepped on something and it bit me. I'm like, no, didn't bite you. So, you know, we had talked about the jellyfish and man-o-war doing the, gotta do the saline first and then the hot water. This one, not so much like that. You're not going to release any more toxin or anything. Honestly, it just, you irrigate it, you can use water, you can use saline, whatever, it doesn't matter. Supportive care depending on if they present with any other symptoms. Obviously, remove the barb for anything that stabs you or bites you, you want to make sure there's no foreign bodies. And then you want to immerse in hot water. Again, kind of like the jellyfish treatment after you get the stuff off of them. You want to immerse for about 30 to 90 minutes. The problem we always have is finding a container in which to immerse in. And I don't know if they need to start making things that are easier to use as far as that goes, because we always get these people who are up here like stung, and then we can't put it in anything. But really pain relief, tetanus prophylaxis on any of these guys that are bit or stung by anything. And then antibiotics are controversial. Like I say, I usually do it. Some say only if infection develops, but others say it's a big infection risk to go ahead and do it, especially since these barbs can go kind of deep. And usually the problem comes in the kids arena, because you got to think about Vibrio, which can kill people, and it's not, and usually we use Doxy, but then we don't, or Cipro, but we usually don't use those medicines in kids. So I always have this hard time coming up with which antibiotics. What's that? Vibrio is like that, you know, if you eat raw oysters, and they talk about that bug that can get you really sick. That's the one. And usually you present in sort of a late stage, and it's a pretty deadly sort of bug. Very rare, but to actually get an infection with it, but something to consider if it's an ocean induced laceration. So sharks, we don't see a lot or any of these, and interestingly, the risk of attack is 1 in 5 million on the North American coast, so you're much more likely to get stung by a jellyfish or stabbed by a stingray. But treatment is supportive, and it kind of depends on how big the wound is and where the wound is. But manage the bleeding, obviously the wound, tetanus, and you know, since it's most likely a deep wound and it's from a dirty mouth, you do want to give antibiotic prophylaxis. So these fish, I'm not sure how prevalent they are around here, but I know like in the Keys, they kind of rule the roost down there. But zebrafish, scorpionfish, and stonefish, those are definitely poisonous. Usually found in the sand. The venom apparatus is within their spines, usually on their back or their posterior areas or the pelvic spines. You can get just local symptoms, but you can also get systemic symptoms, especially from the stonefish can be particularly dangerous. But kind of just like everything else that's in the sea, you want to immerse it in hot water, because most of these are heat labile toxins. And so you just immerse it in hot water until the pain improves. Just make sure they don't have any other symptoms along the way, and then go from there. Catfish, have a lot of those around here. So their venom apparatus is in the spines on the dorsal and pectoral fins. The spines themselves, not the little whiskers on the front, but the spines can actually get stuck in the wound, increase risk of infection, foreign body reaction, that kind of thing. So just like everything else, you irrigate it and then you soak it in hot water. And then again, since there's a possibility something might be stuck in, might want to consider an x-ray, make sure there's nothing still left in there, debride is necessary, and then they definitely recommend giving prophylactic antibiotics for these guys. And pretty much like everything else, if you're going to need to close it, you want to do delayed closure. Sea snakes, not around here, thank gosh, but interesting nonetheless. So usually Indian and Pacific Oceans, or at least, I don't know if we have any sea snakes indigenous to this area, but they're at least not the deadly ones. There's 62 different types. Usually it's a painless bite, but then you can die within a couple hours from that. So you get this progressive paralysis, and then your muscles start breaking down, which leads to your potassium being elevated, which can then lead to a heart attack. And so over in Australia, where they have a lot of bad things in Australia. Keep that in mind if you ever go scuba diving or snorkeling over there. But they have anti-venom over in Australia, and they actually say for anyone that gets a bite, because they're so deadly and because the symptoms are kind of quiet until boom, they hit you, they say everyone gets anti-venom. Pufferfish, although not so much common around our waters, some people do serve it as food, which isn't the smartest thing to do. They have a toxin called tetrodotoxin, which is a sodium channel blocker, and you can't get rid of it by cooking. And so apparently, I don't know who'd want to risk their lives by doing it, but apparently you can buy the fish, I think it's called, I don't know if I'm pronouncing it wrong, but fugu or something like that. And basically they have to get a particular part of the fish and cook it just right, but it's like I said, it's not inactivated by cooking. So it's like a very particular part of the fish. I don't know why you would do it. But either way, you get like this perioral sort of numbness and tingling, followed by gradual paralysis. And usually you're actually totally conscious, and so that's the worst part of it, is you're totally conscious and you can't move, and then you stop breathing. So treatment is supportive if that would ever happen, but if for some reason someone's like, I was eating a fish in a restaurant And I don't even know if they sell it around here, but, and then my mouth started getting really numb. You want to definitely hold on to those kind of people.
Does it wear off?
That's a good question. I honestly don't know if there's like a certain sort of threshold of venom that you have to get that will either put you over the edge into full paralysis or not. I would presume there is. Like, I would presume that some people just get that, and then yeah, it does eventually wear off. Like, even if you're like full-blown paralysis, usually it wears off. You just got to take time. I'm not sure how long it takes though. These guys also not around here, but I thought they were really interesting. So they're usually like a muddy brown color, and when they get ticked off and you scare them, their little rings light up in this fluorescent blue, and so that tells you to back up. They're pretty small. They're about 6 inches big, found around Australia, again. And if they bite you, they literally bite you. They also have the same stuff as the pufferfish. They have the tetrodotoxin too. So they also can cause numbness, tingling that progresses to paralysis and respiratory failure.
The pufferfish are poisonous and touch them, just eat them.
Correct. Yeah. Probably just hurts if you touch them. But yeah, the eating of it is bad. So Ciguatera, so now we're kind of getting into foodborne illnesses. Ciguatera is a pretty common foodborne illness from reef fish. So things like barracuda, grouper would obviously be really common around here, snapper. And they're these little one-celled organisms that live on reefs that infect the fish, and they're the ciguatoxins. And it causes about 20% of foodborne illnesses. And the mortality is really low, about 0.1%, but it's still there. What they usually test us on is that even though it's not pathognomonic specifically for Ciguatera, hot-cold confusion, so like if you stuck your hand in cold water, you thought it was hot, and vice versa, that sort of thing is common in this. Numbness, tingling, GI symptoms, you can get cardiovascular symptoms. And the weird thing about this is you can get sort of relapse, kind of like malaria, you can get relapsing symptoms for years after. I don't know, I've never seen anybody with it, but you just treat supportively. Things that we do see around here, I don't know if anyone's ever seen related to like foodborne illness, but I know when we have red tide algae blooms, you get a lot of respiratory illnesses. But if you actually eat something that's infected with red tide, then there's 3 main types, which are kind of self-explanatory: paralytic, neurotoxic, and diarrheic. And it's supportive care from those guys too. So be careful if we have a lot of red tide and you eat from a local fish restaurant. Scombroid poisoning, I'm pretty sure I had this a couple years ago. It's named after the families of fish that it's most commonly in, so like mackerel and tuna. But it can also be in other types of fish like mahi-mahi, trout, swordfish, a lot of stuff that we eat around here. It can also be in Swiss cheese, which is just a random side note. But it causes about 40% of seafood-borne illness in the U.S. and in Europe. And the interesting part of this is that it's due to the improper storage of fish, usually like at the fisherman's standpoint. It could be later too, but what happens is they catch the fish, they might not keep it cold enough, and inside the body of the fish they have histidine, which converts to histamine. And if you think of eating a whole lot of histamine, it's like that sort of thing. You know, you take antihistamines, which help with, you know, flushing and feeling icky and that sort of thing, and this is the opposite. So it makes you have all those symptoms. So all that histamine is what happens. And regardless of how well they cook it, you can't get rid of the histamine once it's formed. So sometimes, so you got to be careful about fish that are like heavily seasoned, because I'm pretty sure I had this when I had like these fish tacos, and I came home and I had like all the symptoms besides like arrhythmias and hypotension. But it might taste peppery or bubbly or nasty, so beware, and you might want to take a Zyrtec or something. But within an hour or a couple hours, you might get some symptoms like skin flushing. You could get sort of allergic type symptoms like hives or that sort of itching. Headache and diarrhea are very common. You can get short of breath, chest tightness, that sort of thing. Usually goes away on its own within about a day or two, but you can help reduce the symptoms with antihistamines, so Benadryl, Zyrtec, that kind of thing. And if it's really bad and they're having anaphylactic symptoms, then obviously treat accordingly. So land invertebrates. So the icky crawlies. So brown recluses, usually outdoors or in dark areas like closets. Usually the brown recluses, as compared to the other spiders and bugs, this is the one that people get confused with, like MRSA, and that's how they always ask us, oh, do I have a spider bite kind of thing. No, you don't have a spider bite. But if you're going to have it, usually you get like this little pustule that then develops into an ulceration over a couple days. And the treatment of it depends on how bad that ulceration and necrosis is after a couple days. So people can get systemic symptoms, so they can get like blood pressure problems or, you know, malaise, flu-like illnesses, that sort of thing, but usually really uncommon and usually in the frail, so the small children, the elderly folks, that kind of thing. And usually that's within a few days of it happening, but generally it's just local symptoms. So treatment usually is just supportive and local wound management, but if it's technically, if the necrosis is over 2 centimeters in diameter, you want to debride it and you want to give antibiotics. I don't know. I've never actually seen a brown recluse spider bite, but I've seen the spiders, but not the bites. And if you're going to get the systemic symptoms, usually the mortality is due to hemolysis, respiratory failure, kidney failure, that kind of thing. So black widows, these are the ones more that give you systemic symptoms. So if you get bit by a spider and you have really bad systemic symptoms, you assume it's a black widow bite. #1 cause of death from spider bites in the United States. They have the little red hourglass. I don't know who's going to get down there close enough to look, but that's what they've got on their backs. The males, interestingly, are a lot tinier than the females, and their fangs actually can't penetrate skin. So it's always the females that are the ones doing the badness. And the venom is actually a neurotoxin. So, like we talked about, usually this is if you get bit by a spider and then you have systemic symptoms within a few hours. The actual local bite is actually pretty painless and not so much of a deal. But then you start getting overall sort of pain and crampy pain and myalgias, and then muscle rigidity. And then you actually can lead to respiratory distress, lots of other random stuff. So the mortality from black widows, although we think of it being terrible, is only about 5%, which is still a lot, but that's in adults. But in kids, it can be up to 50% mortality. And I don't know if maybe it's just because you never know what kids are getting into, and so you kind of don't recognize it until it's too late. Usually that's what happens with kids in general. But like we talked about, you assume a black widow bite if there's lots of pain and muscle rigidity after a spider bite. And this can even be to the point where they're having like super bad abdominal pain, and so you might get confused with an acute abdomen or appendicitis sort of situation. Tick paralysis, although we don't have a lot of ticks around here, the interesting thing is that it can cause paralysis. So wood, dog, and deer ticks can sometimes carry this neurotoxin where they latch on. While they're still latched, they release this neurotoxin that causes this ascending paralysis going up your body, and then eventually like cerebellar dysfunction, so you're not really walking straight or acting right. And the treatment is just to remove the tick, and that's easy enough, and then the symptoms go away. So never seen it, but you'd save the day if you found the tick. Moving on to land vertebrates. So the creepy crawlies again. So snake bites, near and dear to our heart here. So the endemic U.S. venomous snakes include the crotolid and the elapidae. So the crotolids are the pit vipers. That includes your cottonmouths, so your water moccasins, your copperheads, and your rattlesnakes. Rattlesnakes are the most common. I mean, honestly, around here we have more water moccasins, but this is sort of U.S. Numbers. Elapidae really just includes the coral snakes, is all we care about. And that's, although they're pretty deadly, it's only about 1% of serious snake bites. And I know before I started here, I know we had one here, I think, years ago, didn't we? I think? I don't know. At least I thought I saw something in the newspaper a long time ago. But crotolids, so pit vipers, generally you can tell they have triangular heads. They have elliptical, sort of cat-like pupils, vertically oriented elliptical pupils. Again, I probably wouldn't be close enough to identify that, but if you were. And then water moccasins, they are called cottonmouths because they have a white oral mucosa. So pit vipers, so you get, it's really a really bad local reaction that then spreads systemically and gives you like coagulopathies and DIC, but the badness of it starts locally. So worsens over the first 24 hours. So when they come into you, it's going to get worse, most likely. And if untreated, it develops into necrosis and you can die. Flu-like symptoms signal more systemic absorption. So some of these snake bites are dry bites, so you might not get any venom. Some of it, and the rest of them sort of depends on how much venom they actually instill. But you can get DIC, coagulopathies, paralysis. You can pretty much get anything bad. And then on a side note, you got to keep in mind there's a lot of nasty bacteria in the snake's mouths. So as with anyone, you want to make sure that airway, breathing, circulation is taken care of. After that, you want to immobilize the extremity, remove all constricting items because it's going to swell, and you don't want some, ring around their finger or a bracelet causing them even more vascular issues. Tourniquets, kind of I wouldn't say hot topic, but controversial topic. generally the consensus is if you're going to use a tourniquet, it's really just out in the field, and it's really if you're there within an hour. And the problem is, though, it's got to be constricting enough to cut off venous flow and lymphatic flow, but not so constricting where it cuts off blood flow, like arterial flow. So you got to still have pulses, but then you got to be cut. So I don't know. It doesn't help that much, and you can have more problems with it, so it's probably not the best idea. Now, if they do come in with a tourniquet, you got to be careful. You don't want to remove the tourniquet until you start the antivenin. Because once you remove that tourniquet, it's going to release the rest of the, if it was working correctly, it's going to release the rest of the antivenin, and you can get worsening symptoms. Incision and suction, like you see in some movies, are a big no-no. That doesn't help and then isn't pleasant either. And then Crofab actually is the treatment. So Crofab, they used to make a horse-derived serum antivenin, which had a lot of sensitivity issues and reactions associated with it. And so they've made it from sheep since 2000. So new is a relative term, but it's used for rattlesnake and water moccasin bites, copperheads in particular. It's not really used for unless their symptoms are terrible, because they don't actually incorporate the copperhead venom into the antivenin. So it really works from water moccasins and rattlesnakes best. The best is if you use it within 4 hours of the bite. You can use it within 12 hours. If it's over 12 hours, the only reason you would use it is if they had some persistent coagulopathy or something like, or if they were in, real bad shape. So random comments. So if someone brings in the head of a snake and is like, hey, this is what bit me, apparently up to an hour after decapitating them, they can still bite you. So be careful. Yeah, kind of interesting. But you kind of want to sort of get a rainbow tube on them too. So you really do want to check their coags. You want to look for end organ damage, that sort of thing. Type and screen them in prep that they might need blood products. And you want to frequently monitor their extremity circumference and really just keep an eye on how fast things are going. Clean it locally, as with any of these other bites and stings. Tetanus prophylaxis. And then, like we talked about, you don't want to excise or incise the wound. That doesn't help at all. You don't, they talk about performing fasciotomies to help with blood flow, but usually that's not going to help because it's not that deep of a wound. And then ice actually can lead to more necrosis, so you don't want to do that either. And then if you're going to get shocky from it, it's usually within the first couple hours to the first 24 hours. So which one's bad? Yeah, you got it. So top one's bad. That one I still wouldn't really wouldn't do anything with, but no, it's not going to kill you, so that's good. So although this is the red on black Frenda jack is really just in the United States. When I was studying for my boards, I found out that there are other coral snakes in that family, like in South America and stuff, that actually don't have that pattern, but can still kill you. So keep that in mind. Don't go approaching random snakes in South America. So coral snakes actually, unlike the pit vipers, they actually have rounded pupils. They have more of a rounded head, but their coloring obviously is the striking thing that kind of gives you the hint of badness. Now, if you go back, the snout is always black. So as you can tell in the coral snake up top on the left, the snout's black, whereas in the king snake down here, it's actually a reddish tone. So that was interesting and something I never really thought about before. But yeah, people have little plays on words. So red on yellow, kill a fellow. Red on black, either friend of Jack or venom black. It's funny. Yeah, I knew that you grew up with Friend of Jack. Yeah, so did I. And then when I went up north for my training, they're like venom black. I'm like, no. I'm like, that's silly. But basically, you might get some local wound irritation or numbness or that kind of thing. But the problem is their venom is a neurotoxin, and the local issue is not the problem. Over a couple hours, you'll get sort of weakness, you'll get bulbar symptoms, so like cranial nerve symptoms, you won't be able to swallow, you might get facial drooping, that kind of thing, and then you stop breathing. So if you get bit by a coral snake, you got to watch them for a while, make sure. So they actually, because the demand's not quite high enough, Wyeth used to make an antivenom, but now they don't make it anymore. So it's not been made for years, and so I don't even know if we have any, but the people that do have some, it's generally expired, but the FDA says use it if you get bit. It'll still work. Just like with the pit vipers, tourniquet suctioning, other local methods don't really do anything. You still want to clean the wound and that sort of thing and do your tetanus prophylaxis and that kind of thing, but generally it's just watching supportive care for any systemic symptoms that arise. Dog bites. We unfortunately see lots of those. So dog bites are about 80 to 90% of most mammalian bites. The other ones generally are more like your cats and humans. But usually it's local crush injuries. They have very strong jaws, produce up to about 400 pressure per square inch. per bite, enough to technically perforate sheet metal. So you can do some pretty big damage. And for us on the kids side, you got to consider if they got bit in the face, make sure that it wasn't a big dog with a little head, because they can actually puncture the skull and cause an intracranial bleed, lead to badness in there. So even though they might have just gotten bit in the face, you got to check for other places too. Most common bugs that we worry about are going to be your staph and your strep, but then specifically for a lot of the animal bites and the mammal bites, you worry about Pasteurella, which can cause some pretty nasty infections within the first couple of days. Cat bites usually are actually more risk of infection because whereas the dog bites usually lead to like tearing and crush injuries, cat bites are more puncture injuries, and so you can't really clean them well, and they're pretty deep. Generally, you never, even if you got a ripped laceration of a cat, you like never want to close that because it's such high risk of infection. And then cat scratch fever, on a side note, if they just got scratched by a cat, you can lead to cat scratch fever, which is usually fever, local lymphadenopathy, that sort of thing. Which that actually goes away on its own. People usually treat with azithromycin, but it usually goes away on its own. Human bites, thankfully we don't see a lot of those, but like this is including if someone got punched in the, if they punched someone else in the face and got a fight bite, that kind of thing. Big risk of infection, just like cats. Usually staph and strep, and then the oral anaerobes are your most common nasty bugs. But then you also got to consider hepatitis and HIV and syphilis and that kind of thing too. So treatment of mammalian bites, so as with any other bite, you want to clean it out really good and also use betadine. They've had studies that have showed that the saline under pressure, so when we use our little syringes under pressure with the saline, that actually works better than antibiotics for prophylaxis of infection. Depending on the bite and depending on what bit them, depends on if you can sew it up. So usually things that are closer to the trunk are going to be less risk of infection, to the face especially, because there's so much blood flow to the face. It's usually lower risk of infection than like the hands or the feet kind of thing. So if they got bit on the hands and the feet, generally that's a no-no to sew up, regardless of what bit them. But they technically say that you theoretically could suture within 12 hours of the bite, as long as they're not high risk. So high risk, we would do the delayed closure, but that includes your puncture wounds, so your cats, a lot of your mammal, your human bites, hand and foot wounds like we talked about, if they're immunocompromised, if it's been over 12 hours, that kind of thing. And they do recommend, this is a technical recommendation. I give prophylactic antibiotics to everyone because we don't want them coming back with a nasty infection and having to get admitted for infection. But they technically recommend it in these particular types of bites. So the human and cat bites that are pretty deep, so go through the dermis, so go through that sub-Q fat tissue. The prematurely closed bites, so if some other hospital sewed it up too soon, or we did, if it's over 8 hours old and there's a lot of swelling, a lot of crush injury, potential damage to any bones or joints and tendons, and hands and feet. Honestly, like I said, I just do it to everybody, but generally Augmentin is your best coverage to cover your staph, your strep, and your Pasteurella. Not really any other oral antibiotic will do well unless you combine Bactrim and Clinda together, which sounds weird because we usually use either or for like other usual infections. But if they're allergic to penicillin, then you want to use Bactrim and Clinda. And then tetanus prophylaxis, of course. So last but not least, rabies, which I had a kid the other day that was bit by a stray dog, and so it's always a little unclear with like the dog issue, and you usually have to refer to the health department because thankfully rabies is not real endemic in this area, at least in like dogs and cats and that sort of thing. Raccoons and bats, on the other hand, another story, but bats and wild carnivores like foxes, that kind of thing, are just considered to be rabid, so you just do the rabies vaccine. And the problem is with the rabies vaccine, it's such a commitment to do it that you really want to know if you're doing it right or not. Rodents like rats and squirrels and rabbits are not rabid, so I guess apparently they don't carry rabies. But one thing that they always ask us on our general peds boards is like if an infant's in a room, the parents come in the next day and they find a bat, what do you do? And the answer is you actually do have to do the rabies prophylaxis because you can't always see if they scratched them or if they bit them or anything like that. And so if there's exposure to a bat and you're not sure if there was an exposure, you still want to do it because that's such high risk for rabies. And since obviously rabies is a deadly disease that you can't treat. So post-exposure prophylaxis, when they come into the ER, you want to give the immunoglobulin, which half is locally into and around the wound, and half is IM in a different location that then you give the vaccine. And then you give the vaccines just 4 days, 0, 3, 7, and 14 days of exposure. And that was changed years ago from the 5-day regimen, so I guess at least they cut one thing off. And then you want to follow up for signs of infection. But For dogs and such, usually they're not strays, and usually you can do just the monitoring for the 10 days and follow up with their vet kind of thing. Or if they have their vaccines, then that's great too. But the problem comes in when it's some random animal out in the woods. But that is it. Any questions you guys have?
Do you ever see anaphylaxis with any of the like stingrays, things like that? Is there any?
I know, I haven't. You know, I've only been practicing down here almost a year now, so we never, it's not like stingrays in Ohio, what? But I haven't. I don't know if any of you seen any?
No, I was just
I haven't, yeah. I have heard of the like passing out issues and that kind of thing, but then again, you don't know if it's just because, oh, I got stung versus having systemic symptoms. But generally the ones we see, I mean, they usually have to wait like an hour to be seen anyway, so by the time we see them, they're like, no, I'm fine, let me go home. So,
Our biggest problem in this area with anaphylaxis is fire ants.
oh, that's true. And bees, yeah, yeah, fire ants and bees, yeah,
I'm very allergic.
it's true.
Right, and more than bees.
Yeah, I think it's just.
So we see more reactions to fire ant bites than we do to bee stings. And bee stings are usually local.
Yeah,
So and the fire ants,
yeah, they're mean. They're
I've
really
seen
mean.
more, I've seen more anaphylaxis due to peanut butter than I've seen to bee stings.
Yeah. Peggy, you're just
There's no
a
allergic to everything.
badness waiting to happen.
I am with bees.
Oh, hey, Lisa, how are you?
Good. Fill out your eval.
Thanks, honey.
I am. I am generally, it's actually good.